depending on where you are. I just wanted to echo what Dr. Singh mentioned earlier and extend a profound thank you and appreciation for not just Scientex, but all of the previous presenters. Dr. Katzman just, that was incredible. I am in the beautiful Antigua and Barbuda from the American University of Antigua. And today I present a case report on a unique long-term therapeutic approach, specifically the use of a zero carbohydrate ketogenic diet in the simultaneous resolution of vulvovaginal candidiasis and hidradenitis suppurativa. As background, and as we know, Candida species, most commonly Candida albicans, but also Candida glabrata and Candida tropicalis, live as commensal organisms, ubiquitous in the healthy skin, genitourinary tract, and the gastrointestinal tract of human beings, and seldomly produce illness in healthy patients. However, it is the most prevalent fungal pathogen in humans when it does. Candida infections mostly present in the skin or mucous membranes as mucocutaneous candidiasis, particularly in certain patient populations, as we know, such as immunosuppressed patients, surgical patients, neonates, and those with a flora imbalance as a consequence of certain antimicrobial or cytostatic therapy. It is the second most common cause of vulvovaginitis, with clinical features that include intense pruritus with vaginal burning, erythema, and white vaginal discharge. Another cutaneous inflammatory process, hidradenitis suppurativa, is a chronic autoinflammatory skin condition that affects approximately 0.1% of the population globally. It affects regions of dense apocrine glands in folded skin areas, and usually presents in patients initially as a solitary painful nodule that progresses to an abscess, and ultimately, as the disease progresses, multiple lesions appear and are connected by sinus tracts that drain purulent malodorous discharge. Although certain mechanisms underlying the pathogenesis of hidradenitis suppurativa have been investigated, and for example, risk factors have been identified that include smoking, obesity, and a possible genetic component in families with multiple cases in them, a definitive explanation remains elusive. In the absence of a curative treatment as well, and in the face of recurring discomfort and scarring, hidradenitis suppurativa severely deters the quality of life in affected patients. As a result, some hidradenitis patients have experimented with lifestyle modifications, such as the adherence of a ketogenic diet, in an effort to alleviate symptoms. So real briefly, I think we all know that a ketogenic diet is a high-fat, low-carbohydrate dietary therapy. Ketogenesis is activated in concert with gluconeogenesis during periods of fasting, starvation, or the consumption of very low grams of carbohydrates. For the case presentation, the patient, a 29-year-old female with no past medical history, and presented for a routine gynecological examination. On physical exam, the vaginal canal appeared erythematous with thick white curd-like discharge. 3 hyperpigmented, scarred, minimally raised vulvar plaques with subcutaneous sinus tracts that were actively leaking seropurulent fluid was also found. Vital signs were within normal limits, and the patient denied any other ongoing illnesses or family history of similar symptoms. The initial clinical impression was Candida vulvovaginitis and vulvar abscesses. Gynecological cytopathology confirmed the presence of fungal organisms morphologically consistent with Candida albicans, and surgical pathology determined that the lesions were comprised of free hair embedded in granulomatous inflammation, fibrosis, and ruptured follicular cysts, supporting a diagnosis of hidradenitis suppurativa. The patient was given a referral for surgical removal of the cutaneous lesions and prescribed a course of fluconazole for the Candida vulvovaginitis. Despite insistence from providers, the patient refused the standard of care and instead notified the clinical team of the intention to embark on a zero carbohydrate, all meat ketogenic diet. The regimen consisted of 70% of total daily calories from fat, which was approximately 2,120 kilocalories, and 30% protein, which was approximately 890 kilocalories. So Trivida acetoacetic acid reagent strips were utilized for urinalysis to monitor urine acetic acid value in millimoles, as well as the keto glucose and ketone kit to monitor plasma levels. Glucose ketone index was then calculated to target therapeutic ketosis, which is approximately 1 to 3.0. Initially, trace amounts of acetoacetic acid were found, followed by a small and moderate levels in the urine. The predicted zone of therapeutic ketosis was achieved 17 days following dietary restriction, and mucocutaneous candidiasis as well as hidradenitis symptoms ceased in approximately 6 weeks. Subsequent follow-up visits up to 47 months confirmed the resolution of all signs and symptoms of both the patient's vulvovaginitis or hidradenitis suppurativa, and no further symptomatology has appeared since the patient's adherence to the diet. So possible mechanisms by which a zero carbohydrate ketogenic diet may be therapeutic as intervention for mucocutaneous candidiasis and hidradenitis include the possibility that a restricted zero carbohydrate ketogenic diet is anti-inflammatory and can therefore minimize chronic inflammation, states that are seen in hidradenitis suppurativa and candida vulvovaginitis. Not to bore everybody with all the biochemistry that we learned so long ago, but during gluconeogenesis, which is activated by a zero carbohydrate, high fat, low protein diet, glucagon activation of cyclic AMP cascade in liver inhibits glycolysis, therefore limiting pyruvate production from carbohydrates. The pyruvate that is created from lactate or alanine is converted to oxaloacetate by the enzyme pyruvate carboxylase, which is further activated by acetyl-CoA. The oxaloacetate is converted to malate for gluconeogenesis, but due to the low level of oxaloacetate, the acetyl-CoA is directed to ketogenesis rather than used for energy metabolism in the tricarboxylic acid cycle, also known as the Krebs cycle. High ATP concentration produced during fat metabolism inhibits the TCA cycle at the isocitrate dehydrogenase step. And ultimately, acetyl-CoA produced by beta oxidation of fatty acids is converted into ketone bodies. So ketone body metabolism provides the body's normal cells, including macrophages and neutrophils, with a metabolic advantage over fungal cells due to an increased change in the Gibbs free energy of ATP hydrolysis, approximately 56 kilojoules per mole to negative 59 kilojoules per mole. Normally, macrophages and neutrophils phagocytose Candida albicans, and the oxidative killing is the first line of host defense, illustrated by increased risk of Candida albicans infection in individuals with neutropenia or defects in oxidative enzymes, NADPH oxidase or myeloperoxidase. Thus, a more energized arsenal for phagocytes as a result of ketosis improves the elimination of Candida species overgrowth, and a similar mechanism in the inflammation as seen in hidradenitis. So in conclusion, ketogenic diets were first popularized in the early 20th century for their efficacy in management of refractory epilepsy. Since then, they have gained recognition for concurrent or complementary therapy for specific chronic inflammatory diseases. But since case reports are inherently limited in their ability to draw causality, further studies may draw an association between the effectiveness of ketogenic diets and vulvovaginitis and hidradenitis. I just want to thank you so much for your attention and for allowing me to present, and I really look forward to the remaining presentations. Thank you.
Thank you, Nadia. That was an excellent presentation. Thank you, ma'am. And we came to know about these kind of case report also. We were not aware. So thank you so much for your time, and thank you so much for this presentation. It was very excellent, and I hope it has benefited our participants too. We got to know about something new, kind of case study you have mentioned. Thank you.
Thank you so much.
So now I invite our next participant, Dr. Roger H. Coletti from Interventional Health, USA. So you can proceed with your presentation. Thanks for the patience.